Hi everyone, welcome back. My name is Sanjana, and today we'll be talking about transplant rejection. So, in transplant rejection, there are two things that we have to discuss. One is the types of transplant, and second is the types of rejection. So, coming to the types of transplant, there are four types of transplant: the autograft, the isograft, the allograft, and the xenograft. So, autograft is a type of graft where the tissue is transferred from one side to another within the same individual. Example for this will be a skin graft for a wound, taken from one side and used to cover another part. Next is the isograft, a graft where the donor and the recipient are the genetically identical. So that means monozygotic twins. In this, the rejection is less likely as they are genetically the same. Next, coming to the allograft. The allograft is a type of graft in which the two individuals are not genetically identical but belong to the same species. For example, is this a normal organ transplantation? Next is the xenograft, a graft between individuals of different species. Example for this will be using pig heart valves in humans, and recently would have also heard the example of using pig kidneys in another human. It was a clinical trial that was conducted. In this, the rejection is high. Next, coming to types of rejection. In this, we have again four categories: the hyperacute rejection, the acute rejection, chronic rejection, and the graft versus host rejection. So, coming to hyperacute rejection, here the onset is within minutes to hours. Mechanism is by pre-existing recipient antibodies, okay, that react with the donor antigen. This is an example of a type 2 hypersensitivity reaction which further activates the complement. So what are the features? Grossly, there is cyanosis and mottling of the graft, and histologically we see widespread thrombosis, and also we see necrosis. So what's the management? We immediately remove the graft. Coming to acute rejection. In acute rejection is between weeks to months. So the mechanism is predominantly cellular. Okay, so the CD8 T cells and CD4 T cells are activated against the donor antigens or MHCs. In humoral, there are antibodies that develop after the transplant, and the main thing is CD4 deposition. So what are the features here? There's vasculitis, and we have to remember that there is dense interstitial lymphocytic infiltrate and endothelitis. So basically it affects the blood vessels. Okay, management here will be to prevent or reverse it with immunosuppressants. So they react to immunosuppressants. Coming to chronic rejection. So here the onset is months to years. So previously acute rejection was less than 6 months. Chronic rejection is more than that. So here mechanism is mixed cellular and humoral components, that is the type 2 and type 4 hypersensitive reaction. Here the CD4 T cells respond to the recipient antigen presenting cells that present the donor peptides. What are the features here? It's mainly and dominated by arteriosclerosis. So the recipient T cells produce cytokines that induce the proliferation of vascular smooth muscles, which causes parenchymal atrophy and interstitial fibrosis. The word atrophy and fibrosis is very important, and also it is having arteriosclerosis. What is the management? Management is irreversible, so it is refractory to immunosuppression. Coming to organ specific examples, this is really important as we'll have cases based on these. One is the chronic allograft nephropathy, the bronchiolitis obliterans, the accelerated atherosclerosis, and the vanishing bile duct syndrome. It's important to learn a little bit about each of these, and these are really specific for chronic rejection. The bronchiolitis obliterans happens in lung transplantation, whereas the chronic allograft nephropathy is the main cause of renal failure post kidney transplant. Now, graft versus host disease. Here, the onset is variable. Okay, there is no specific onset. The mechanism is grafted immunocompetent T cells proliferate in the immunocompromised host and reject the host cells. So Here there is severe organ dysfunction, and the main hypersensitive reaction is type 4 hypersensitive reaction. What are the features here? There's maculopapular rash, there's jaundice, there's diarrhea, there's hepatosplenomegaly. So these are usually seen in organs that are rich in lymphocytes. This can be potentially beneficial in leukemia patients. So how do we manage it? By irradiating the blood products before transfusion in immunocompromised patients. So I have a few set of cases, clinical cases. So let's discuss. A 50-year-old woman with end-stage renal disease is scheduled to undergo kidney transplantation. While on the operating table, the donor kidney is connected to the patient's blood supply. Within minutes of perfusion, the transplanted organ becomes extremely erythematous. After a short period of time, the kidney becomes ashen grey and urine production ceases. The surgeon immediately removes the organ. What do you think is the case about? So here we can notice that it is during transplantation, that's one thing, within minutes of perfusion, and also the graft is mottled, right? And the surgeon immediately removes it. So this gives us an idea that this is an example of acute transplant rejection. It's a type 2 hypersensitive reaction, right, and needs immediate graft removal. Now coming to the second case. Second case is a 50-year-old male kidney transplant recipient presents with gradually worsening kidney function over several months. His serum creatinine has been increasing and he has mild proteinuria. He has been compliant with his immunosuppressive medications and there are no signs of infection or acute rejection. On ultrasonography, the transplanted kidney is reduced in size and a renal biopsy is performed. What does this reveal? So in this, we notice that it is worsening of kidney function over past several months, right? Several months. And gradually the serum creatinine has been increasing. He has been compliant with immunosuppressive medications, but his ultrasonography reveals transplanted kidneys reduce in size. So that means there is atrophy. So this is an example of chronic rejection. So on renal biopsy, we will see parenchymal atrophy and interstitial fibrosis along with arteriosclerosis. Next, a 40-year-old male who underwent a lung transplantation 2 years ago presents with gradually worsening shortness of breath, cough, and wheezing. Pulmonary function tests reveal obstructive airflow limitation. Chronic transplant rejection is suspected. Bronchoscopy with transbronchial biopsy is planned. Histopathology is likely to show injury involving. So here we first of all notice that they have already given us lung transplantation and chronic transplant rejection. So give us two keywords. And next they have said shortness of breath, that's dyspnea. So we have to now rule out chronic rejection and lung transplant. So that could be best example, like I mentioned, organ specific example, bronchiolitis obliterans. Okay, here the small airways, right? Small airways are affected, which results in dyspnea. Small airways, there are granulation tissues that leads to airway obstruction, obliteration. So this results in slowly worsening dyspnea that happens for months to years. We know that it's 2 years after transplantation. Got it? Yeah. I hope this helps. Thank you so much for your patience and time. Have a great day ahead. Bye.